Thank you, sir. So I would like to invite next speaker, Dr. Vishakha Jain, for the talk on a rare case of unilateral VKH. Meanwhile, I would also request the next speaker to be ready with their talk. Thank you.
Good morning, everyone. I'm Dr. Vishakha Jain from MNGI Institute, Ahmedabad. I'm presenting a case of unilateral VKH. VKH is a multisystemic inflammatory autoimmune disorder that is characterized by panuveitis with iridocyclitis, serous retinal detachment, diffuse choroidal swelling, and optic disc hyperemia. It may be associated with neurologic and cutaneous manifestations. It has 4 stages: prodromal stage, acute uveitis, convalescent, and chronic recurrent uveitis. The ocular manifestations are typically bilateral, but an asymmetric severity is usually present. There are few reports on unilateral VKH disease, and some of them are delayed forms of bilateral diseases. Here we describe a unilateral case of VKH disease. A previously healthy 48-year male patient presented with complaint of painless diminution of vision in right eye since 1 week, which was not associated with any redness, watering, or photophobia. There was no history of any penetrating trauma or intraocular surgery. No history of joint pain, any chronic systemic condition like TB or syphilis, and no history of any similar attacks in past. Ocular examination shows right eye vision was counting finger 4 meters and left eye was 6'6". On anterior segment examination, right eye shows RAPD and rest anterior segment was normal. In left eye, anterior segment was normal. Fundus of right eye showed hyperemic disc with serous retinal detachment along superior and inferior arcade, and left eye was normal. We did investigations. First was OCT. OCT showed bacillary layer detachment with neurosensory detachment with RP undulations and subretinal septa forming multilobular cystoid spaces. This is the video of OCT of right eye, which showed septa, multiple fibrous septa with elevation and fluid. It is typical of VKH, while left eye it has normal foveal contour. On USG, there was choroidal thickening representing acute phase of disease, and there was a smooth dome-shaped highly reflective retinal membrane, which is suggestive of serous retinal detachment. And then we did fundus fluorescein angiography, which showed a typical picture of VKH. In early phase, it showed choroidal hypofluorescence followed by pinpoint leakages. And then in late stage, there was a leakage and pooling of dye, which showed serous retinal detachment. And FFA of left eye was normal. We did lab investigations, which were all normal. The DD could be CSCR, sympathetic ophthalmitis, and posterior scleritis. Treatment we gave was we started patient with oral prednisolone for 1 week, and after 1 week patient was prescribed tablet methotrexate 15 mg once a week along with the tablet folic acid, and steroid was then tapered. After 1 week of steroid course, the visual acuity of right eye was improved to 6/36 and the lesions also regressed, and after 3 weeks the visual acuity reached 6/9 and OCT was absolutely normal. This is the fundus picture before treatment, which shows localized serous detachment and hyperemic disc, and this is the red-free photo of the fundus. And after treatment, the lesions regressed and the RP alteration was present. This OCT was before treatment and after treatment. Thank you.
Thank you, Vishakha. I think it's a very common thing that we see, particularly in India, unilateral VKH. It's not VKH, it's mainly the Harada's disease, which is more commonly seen. comments from Navneet, Dhanashri.
Posterior scleritis, because VKH is a described term for a bilateral disease until and unless ICG is done and it shows some subtle changes in the other eye, because ICG was not done in this case. More involvement only of the one eye with bacillary layer detachment and exudative kind of detachment. It could be, I think, just a posterior scleritis.
So I think ICG is not available in majority of the institutions,
Yeah.
and our corollary to that, I think a very good investigation is the EDI, the
Yeah.
enhanced depth imaging.
Yeah,
I think that is a very important, not only a diagnostic but also a follow-up. And it is an excellent tool on your response to treatment, and also it gives you an early clue that that's going to be a recurrence. Usually patients present to us on follow-ups, and if you see that the EDI, the choroidal thickness is again increasing, he is going to develop an attack. So this is a very important tool. You surely do not need ICG, but I think EDI is a
Yeah,
must for
agrees.
VKH.
But that's why if the other eye EDI been done, choroidal thickness
They would have
is
shown
seen,
thickness.
or in sonography thickness is seen. So then we can label it as unilateral VKH. But otherwise, I think
It's Haradas, I think, not full-blown
or
VKH.
maybe posterior scleritis.
One alternate is, now that we have newer OCT machines, we have integrated OCT angio. OCT angio is a very good investigation, very similar. We'll get similar hypo dots on OCT angio as we get in ICG. So if you have a unilateral case and you have to rule out if the other eye has involvement or not, in the other eye, we can get an OCT angio to look for those hypo spots.
I agree with you. We did this study a few years back, OCT angio in VKH. We saw that hypo, and then later with treatment they improved. But it was very difficult to differentiate whether it's just because of VKH, because a lot of entities
Yes, so
present
in
similar.
acute where there is exudative RD, then it is not reliable. So when the RD has settled, then for detecting the early recurrences, and in this case where there is a unilateral presentation, you want to see subclinical other eye involvement where there is no edema, there OCT angio will play a role.
Dhanashri, comments? Unilateral VKH cases. I think we see more in younger age groups. That's fairly common, even younger patients, even pediatric age groups. We see a lot of unilateral pediatric patients presenting as unilateral Harada's disease.
No, I agree with you. I'm not a uveitis specialist, but I think there can be sequential involvement of the other eye.
Yes.
And if you have a follow-up of this case, I don't know how much follow-up you have.
Ma'am, we did follow up for almost 2 months, but there was
Okay.
no involvement of the other eye. And involved eyes was also improving.
And also because you have treated the patient also, so that is also one thing. But supposing the patient doesn't receive any treatment, there is a possibility the other eye may get involved down the line. So I think a good long follow-up also is important. But as you said, and as whatever discussion was going on, it's important to note whether the other eye shows any signs of subclinical involvement.
And also it is important to keep treating these patients for long. Even after they resolve, you need to give them long-term immunosuppressants. And you have to start the immunosuppressants early. So along with your steroids, it's been shown by literature, if you start immunosuppressive along with steroids, continue the immunosuppression for a longer time, then there are lesser chances of recurrences.
Two things. One is OCT2 features. One is the seeing the cells in the posterior vitreous, and the type of undulation what you see in the VKH.
Yes, ma'am.
That helps in differentiating between the posterior scleritis and VKH.